Now let's talk about intrinsic factor and vitamin B12 absorption. So B12 absorption's a pretty complex pathway. So let's kind of go over, you need all of these things to be working in order to absorb B12. It's actually pretty hard to absorb B12. So you need adequate intake. We need to produce our binder. We need to produce intrinsic factor in our stomach. We need pancreatic proteases. We also need normal intestinal bacteria levels, a healthy terminal ileum, and adequate liver storage. So I'm going to go over all of that so we can understand what's going on and why we need each of those 7 things in order to absorb B12. Well, the first thing is that B12 is consumed and it's bound to animal product when it's consumed, okay? Our binder gets produced in the oral cavity and all of these end up into the stomach. What's going to happen is the stomach will encounter this B12 animal protein complex and it will cleave this B12 and animal product. Now, if you don't have our binder, the B12 would just get degraded right away. But because our binder is also coming into the stomach, B12 will bind to our binder to protect it. While this is going on, intrinsic factor gets produced, and all of this B12, RB complex, and intrinsic factor all travel to the small intestine together. Okay? And remember, intrinsic factor at this point is just free flowing. It's not actually bound to the B12 yet. Next step is that we need to get this B12 and R binder disconnected. R binder's done its job. It carried B12 from the stomach to the small intestine. And so now we need pancreatic proteases to come along and cleave this to give B12 a little bit of freedom. Once B12's free like this, intrinsic factor that's also free can now bind to B12. And these together can start making their way all the way through the small intestine. So they're going to travel all the way through the small intestine and they're going to reach the terminal ileum. And there they're able to be reabsorbed at the terminal ileum. So we can bring them into the bloodstream this way. And from there, we can have up to a 5-year store, I think it is, in our liver. So it's going to travel to the liver and it can get stored there. And so I'm going to talk about each of these 7 absorption requirements, and we can talk about different conditions that may contribute to B12 deficiency. So first one's pretty obvious. If you don't have enough B12 intake, you might have a deficiency. And because B12 is bound to animal protein, those who are vegan and not taking supplements, they can end up getting the B12 deficiency over time if they're not supplementing. Our binder can also give you it. And so you can think of something like Sjogren's syndrome. I will say that the jury, you're not going to get tested on the R binder stuff. And Sjogren's syndrome also has an association with pernicious anemia, which I'll talk about later. So there's a couple different reasons why Sjogren's might cause B12 deficiency, but I wanted to just let you know that technically speaking, if you have a salivary gland deficiency, there may be some association with B12 deficiency. Now here's what I'm talking about. So intrinsic factor, if you don't have intrinsic factor, you can get something called pernicious anemia, and that can cause B12 deficiency. If you've had a gastrectomy, then you might not have enough parietal cells to produce intrinsic factor. That can also give you a deficiency. Obviously, if you have pancreatic insufficiency, so you don't have enough functional pancreas to produce the proteins to cleave B12 from our binder in the small intestine, then that can cause B12 deficiency. If you have an overgrowth of bacteria in the small intestine, sometimes what happens is that, remember how our B12 intrinsic factor complex was traveling together throughout the small intestine? Well, sometimes those bacteria will come in and they'll cleave that bond, and they might even consume some of the vitamin B12. And so those are 2 ways that you will have a B12 deficiency because of too much bacteria in that region. Remember that the B12 is absorbed in that terminal ileum, so they do love to test that Crohn's disease, which has a propensity to affect the terminal ileum, has an association with B12 deficiency. And they also like to test that this Diphyllobothrium laudum tapeworm is associated with B12 deficiency because it tends to live in that region as well. And the last thing to realize is that if you have liver cirrhosis, you might not actually be able to store as much B12 because you don't have functional liver. And so that is another reason to cause B12 deficiency. Now, how does somebody present if they have B12 deficiency? Well, they're going to present most of the time on test questions, especially with some sort of neurologic symptoms. Okay. You're going to get, and they love this subacute combined degeneration, which I'll talk about right now. So if this is a close up of a spinal section, we can talk about how B12 and subacute combined degeneration works. What it's going to do is it's going to cause damage to two regions. It's going to cause damage to the dorsal columns and the lateral columns. Okay, so the dorsal columns is this region here, and they're responsible for vibration sense and proprioception. So you might have some sort of proprioceptive changes in the patient. And the lateral column, that is part of one of our outflow tracts of movement, motor neurons. So you might actually have weakness, you could have spasticity or hyper or hyporeflexia, depending on whether it's an upper or lower motor neuron lesion. But this combination of decreased proprioception, like you can feel numbness and tingling, as well as a whole host of other neurosymptoms that should lead you into B12 deficiency as a potential cause. You can also get glossitis. I've talked about this in the oral cavity lecture, where most of your iron deficiency and vitamin B deficiencies can cause glossitis. And then on laboratory findings, you're going to find a megaloblastic macrocytic anemia. So let's talk about what that actually means. So you can see megaloblastic macrocytic anemias in either B12 or folate deficiencies. Okay, and so a macrocytic anemia, let's start with that. Macrocytic anemia just means that the average red blood cell is bigger than normal. Okay. Normally, the red blood cell should be between an MCV of 80 to 100. If it's less than 80, it's a microcytic anemia. If it's between 80 and 100, it's a normocytic anemia. And then if it's over 100, you have a macrocytic anemia. Now, from there, you can have a macrocytic anemia that's either megaloblastic or non-megaloblastic. And a megaloblastic anemia is where you have hypersegmented neutrophils. So you have these big neutrophils. Normally, neutrophils have about 3 lobes. You can see that right here. But in megaloblastic anemia, you get 6 lobes. And as we'll discuss, this happens because there's defective DNA synthesis that causes these weirdly shaped multi-lobed neutrophils. Another lab finding you might find in B12 deficiency is an elevated homocysteine and an elevated methylmalonic acid, or MMA level. So let's talk quickly about these. And I'm trying to keep it simple. There's a little bit more biochemistry involved than what I'm going to show, but this is pretty much what you're going to need for step 1 or level 1. So this is homocysteine, and this is methionine. And the only difference between these two compounds is this methyl group right here, the CH3. If you add a CH3 onto homocysteine, you have methionine, okay? Now, it'd be easy if you can just add the methyl group and call it a day. Unfortunately, that's not how it works. You need something to transfer a methyl group from homocysteine to methionine. So how that process works is that you'll have a folate. That folate can gain a methyl group through a couple of different reactions. That folate can then transfer its methyl group to vitamin B12. And then this B12 can help facilitate the transfer from homocysteine to methionine by giving up its methyl group. If any of these, vitamin B12 or folate, are damaged, then you can get elevated homocysteine because there's nothing that can help the homocysteine to turn into methionine with that methyl transfer. And so a big point to note is that you can get elevated homocysteine in either of these vitamin B9, which is folate, or vitamin B12 deficiencies. Another thing I wanted to point out is that this process is also involved in the DNA synthesis pathway. And so if this pathway is damaged in any way, you'll get that megaloblastic anemia we saw earlier because you have defective DNA synthesis. and your neutrophils don't form correctly, and you can form these really crazy like 6 or 8 lobed neutrophils. What I want to talk about next is methylmalonic acid. So methylmalonyl-CoA can actually be converted to succinyl-CoA, and succinyl-CoA is a part of our citric acid cycle. And this process here is facilitated by vitamin B12. And like I said, succinyl-CoA is part of the citric acid cycle, which let me show you. You can see it right here. And our citric acid cycle is really important for us to generate, ultimately at the end of the day, it helps us to generate ATP after you go through the electron transport chain. But anything part of the citric acid cycle is a form of energy. So when this process is defective, like let's say you have no B12, what's going to happen is that you'll have a lot of methylmalonyl-CoA, which can turn into methylmalonic acid. So you can get elevated methylmalonic acid levels in vitamin B12 deficiency. But an important note is that because folate has nothing to do with this pathway, if you have a folate deficiency, your methylmalonic acid level should still be normal. And then, of course, in your laboratory findings, you'll likely find low serum vitamin B12, but they're not going to give you that. They're not going to be so easy on test. They're going to make you think about the symptoms and the homocysteine, the methylmalonic acid levels, or the megaloblastic macrocytic anemia to help guide your diagnosis as well. And here's a chart just to make sure I've reinforced all what the differences between folate and B12 deficiency are. So if we think about megaloblastic macrocytic anemia, they can both cause that. If we looked at the elevated homocysteine level, we saw that they both could cause that. Glossitis, because it's just any B vitamin or iron deficiency can cause glossitis. Now, some of the things that are exclusive to B12, though, the neurologic symptoms, that whole subacute combined degeneration, that's just for vitamin B12. Folate's actually normal in that spot. Okay, folate does not cause neurological symptoms like that. And then the elevated methylmalonic acid, again, because B12 is the only thing involved in that specific transformation from methylmalonyl-CoA to succinyl-CoA, you're not going to see any problems. If you have a folate deficiency, you won't see elevated MMA levels. The last thing about B12 that I want to talk about is something called the Shilling Test. It's pretty low yield now. You'll never see this in real life, but sometimes they test this. I think even on tests it's fallen out of favor, but I think it's kind of a cool way to look at B12 deficiency. So how it works is the Shilling Test has a couple stages, okay? And I've tried to make this as simple as possible. So stage 1 of the Shilling's test is just determining, is there an actual deficiency, right? So how this works is that you're going to give somebody a radioactive B12 by mouth, okay? While you're doing that, you're going to give them an injection of B12. The reason you give them an injection of B12 is you want to saturate all of their B12 stores that are in their body temporarily, okay? And by doing that, you can determine if the radioactive B12 gets absorbed into the bloodstream and peed out later. So what happens is that the B12 injections are given to ensure that the body stores are filled. And then later on, you're going to collect urine radioactive B12 levels, okay? And if you're able to absorb the B12, you'll detect some of that B12 in the urine. And if you can't absorb the B12, you won't detect the radioactive B12 in the urine. So here's our picture. Imagine we intake radioactive B12, and we've already been injected with B12. So our body stores are completely saturated. And what that means is that if any of this radioactive B12 enters our bloodstream, it's not going to be stored anywhere because we're already saturated. And instead, it's just going to be excreted in the urine. And so our kidneys will do their job, and we can identify B12, radioactive B12 in the urine. And on the other hand, if we don't absorb any radioactive B12, then of course, we're not going to find any in the urine. So this is the first step of the Shilling's test. We just want to see, is there a problem, right? And so if we don't detect any radioactive B12, or we detect lower levels than we want of radioactive B12 in the urine, now we know there is a B12 deficiency, right? Next step would be to find out what's causing that deficiency. As you can see from this table, there's so many different things that can cause B12 deficiency, so it'd be hard to pinpoint exactly what's causing it. You could have intrinsic factor problems, pancreatic proteases, SIBO. So there's a lot of different things that can happen. And so the next stage of the Shilling test is to try to determine what's causing the B12 deficiency. So oftentimes the first thing that they test is they want to see if you have intrinsic factor deficiency. So we'll do the exact same thing. We'll give you a radioactive oral B12. We'll give you a B12 injection to make sure everything's saturated. And this time we're also going to give you intrinsic factor by mouth as well to see if that'll um, help with the the absorption of B12. And then you do the exact same thing where you measure the radioactive B12 levels in the urine. And if you detect anything in the urine, that means that it was able to be absorbed now with the addition of intrinsic factor. And so if that was the case, then you'd know, okay, intrinsic factor deficiency was my problem in the first place. So again, this time we have B12 and intrinsic factor. And if it's able to be absorbed this time, and we can detect that B12 in the urine, we've identified that the person's problem here is pernicious anemia. It's an intrinsic factor deficiency. But let's just say, for example, that it's all normal. Again, that tells us, okay, intrinsic factor, I mean, not normal. Let's just say that there was no B12 detected in the urine again. What that tells us is that even adding intrinsic factor didn't solve the problem. So we're going to have to find out another thing that might be causing this problem. So you think instead of intrinsic factor, you can give them pancreatic proteases. Maybe they have a pancreatic insufficiency, and that's why they can't digest B12. Maybe they have such a strong, they might have small intestinal bacterial overgrowth, and that all the bacteria in the small intestine may be preventing the absorption. So giving them antibiotics and then trying this again might be a good way to go about it. So that's what the Shilling test is all about. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.